Hello everyone, my name is Paula Rugg. I've been a registered nurse for 21 years and I've spent the last 8 years in primary care at the White River Junction VA. I struggled initially with a capstone idea, but I knew exactly who I wanted as a mentor. I approached Brenda Sherman, our wound ostomy nurse, and she just happened to be working on a project that involved pressure ulcer prevention in primary care. She was eager to have help from someone on the inside, so to speak. Pressure ulcers have been a major focus for some time on the inpatient settings, but there's not been a lot of research focused on prevention in outpatient settings. The Veterans Health Administration Handbook from August 2016 includes a skincare protocol for the prevention of pressure ulcers. The goal is to standardize the screening, assessment, and prevention of pressure ulcers in all settings. In spite of a written nursing protocol, our outpatient settings have not implemented any procedures. And recently, all VA facilities have come under pressure to change this. The protocol's guidelines for the primary care setting states that every patient is to have an annual pressure ulcer risk screening. Any patient found to be at high risk is to have an assessment, education, and if necessary, care planning. So how do we meet the protocol requirements of standardizing assessments and documentation in a busy primary care clinic? My goal became to create a template that would be easy to use, follow the National Pressure Ulcer Advisory Panel's guidelines, and streamline the assessment, educational, and documentation process. Pressure ulcers are defined as localized injury to skin and/or underlying tissue as a result of pressure or pressure in combination with shear. They usually occur over bony areas like the sacrum, hips, tailbone, heels, even the back of the head. According to the National Pressure Ulcer Advisory Panel, the strongest independent predictors leading to pressure ulcers are patients that are confined to bed, wheelchair use, and have limitations in their mobility. Other factors can contribute to a patient's overall risk level as well. Poor nutrition or tissue perfusion can impair the skin's ability to tolerate pressure. Cognitive impairment or lack of sensation can decrease a patient's awareness of discomfort and their need to change the position. Pressure ulcers have devastating effects on patients' lives. For the patient with intact sensation, there's a great deal of pain. There's risk of infection that can lead to sepsis, even death. Lengthy hospital stays and rehab stays are not only expensive, but they're costly in terms of quality of life, and the social isolation that patients can experience. There may also be legal proceedings involved if there's a question of neglect. In October of 2008, the Centers of Medicare and Medicaid Services declared that they would no longer authorize additional reimbursements for the treatment of certain preventable conditions. Pressure ulcers is one of those such conditions. Pressure ulcers can affect approximately 3 million Americans and cost nearly $11 billion a year. The average cost of treating just one single full-thickness pressure ulcer can be as high as $70,000. The mortality rate for a patient with a pressure ulcer is 2 to 6 times greater than that of a patient with intact skin. And if the patient is elderly, it can be as high as 400% greater. I've been working with veterans since 9/11. It's almost 17 years. And generally speaking, veterans are less healthy than the general population. In 2013, a retrospective study of 29 veterans with nosocomial pressure ulcers revealed that 90% had at least 3 comorbidities and twice the incidence of diabetes than the general population in similar studies. In the service to our country, many of our veterans have been exposed to hazardous conditions that have lifelong health implications. Each military conflict has its own set of different health issues. Agent Orange exposure during the Vietnam era has been linked to the development of diabetes, eczema, Parkinson's disease, the early onset of peripheral neuropathy, chronic dermatitis, and several types of cancer. Veterans serving in Afghanistan and Iraq were exposed to the toxic smoke and dust of burn pits. In these burn pits, jet fuel was used to burn all kinds of waste: plastic, chemical waste, medical waste, human waste, even appliances were burned. Everything was burned. Cold injuries and frostbite can occur when veterans are training or stationed in colder climates. This can lead to possible neurological or vascular injuries. Advancements in protective gear and medical treatments have had some unexpected consequences. Combat vets can survive injuries that would have been fatal in the past. As a result, we see traumatic brain injuries, post-traumatic stress disorder, and multiple traumatic amputations. When I first began discussing my project at work, I found both nurses and providers were resistant to it. The attitude was that we do not need a formal process to recognize a patient at risk. We know our patients very well. Our experience and clinical judgment skills are all that we need. My literature review turned up little research specific to pressure ulcer prevention in primary care. But I did find studies that focused on this very perception in the acute care settings. The evidence suggests that clinical judgment is indeed effective at identifying patients at risk for pressure ulcers. In fact, it's just as effective as the use of a formal risk assessment tool such as the Braden scale. However, it's when nursing knowledge is used in conjunction with a formal tool that care plans get implemented and patient outcomes actually improve. I was also surprised to learn that my mentor had no idea how primary care operates on a daily basis, what the flow is like, or what nurses actually do. So what do primary care nurses do all day? The VA uses a patient-centered medical home model. In the VA, we call these PACT teams. The model intends for every team member to be working at the top of their credentials. The RN role is intended to be one of care managers of complex patients. Nurses have their own scheduled patients and phone calls, and we interact very little with the patients being seen in routine visits with their providers. According to a study of primary care clinic using the same model, the amount of time actually spent on care management is quite limited, unplanned, and reactive. This is true in our clinic as well. The reality, nurses spend most of their time on a variety of simple to very complex tasks that come at us from multiple directions at any given time. How are we going to fit in skin assessments? Creating a documentation template as a progress note was not going to be good enough to ensure that it was done annually. I envisioned a clinical reminder that would turn on annually, prompting its completion. The VA has many such reminders. Mandatory ones are created nationally. Others are created on the local level. Some national reminders are layered or branched. A screening reminder is completed by support staff, and if the screening is positive, it turns on the next reminder, which is an assessment by a qualified team member. This type of reminder allows staff to work to the top of their licensure. This is what I envisioned creating, but I didn't know if one could be created on a local level. Our Clinical Applications Coordinator, often referred to as CAC, her name at our facility is Nancy, she wasn't sure how to create such a complicated reminder. She did know that it would be much easier to modify an existing template than it would be to create one from scratch. The inpatient template was nationally created and could not be modified locally. How was I going to find one that I could modify? I needed to find out what other VA sites were doing. Maybe someone had a working process that we could learn from and build upon. So I emailed the primary care nurse manager at the Manchester VA. I also posted an inquiry on bulletin boards of 2 separate VA special interest groups. I received 3 different responses. Manchester had created such a layered reminder and templates. She sent them to me in the form of screenshots. My mentor and I spent much time discussing the features and modifying them. I presented the final design to our CAC, Nancy. Still unsure of how this layered reminder was supposed to function, Nancy and I met with Manchester's informatics nurse through a video conference. This demonstration was instrumental in giving me the confidence that we could make this happen, and it also gave Nancy the guidance she needed to create our own set of reminders and templates in White River Junction. The screening goes back to those greatest risk indicators we talked about in slide 5, impaired mobility and activity. Any patient who is bedfast, chairfast, or needs assistance to transfer is considered high risk. We also ask about pressure ulcer history. This quick screening step can be completed by the health tech, who completes vital signs and other reminders. A positive response to any of these screening questions turns on the second clinical reminder, the assessment. An RN will perform the Braden scale, skin assessment, education, and skin documentation. We wanted to design the assessment template to be as standardized and easy to use as possible. I couldn't find any research to indicate the best risk assessment scale for outpatient settings. Remember that a formal tool in conjunction with nursing knowledge is important for improved outcomes. The Braden scale is the most commonly used tool, and it has the highest validity for inpatient settings. It is also the scale the VA uses for inpatients. So we start off with the Braden scale. Next comes dialogue checkboxes for describing the patient's skin. Is it dry? Is it moist? Are there any rashes or bruises? Is there any edema? If a wound is present, more dialogue boxes will walk the nurse through proper measuring and staging criteria. Check boxes for wound tissue types, exudate, and signs of infection all include brief descriptors to facilitate a thorough, consistent wound documentation. An educational section allows for free text. It also provides a link that allows the nurse to print out a patient-friendly pamphlet. This pamphlet had been previously designed by our wound care nurse. I reviewed the information it contained to ensure it was up to date. My research process had uncovered a VA-designed mobile app to help patients and caregivers prevent pressure ulcers. This resource information was added to the pamphlet. Finally, the template includes direct links for ordering wound and nutritional consults. Once we had a working prototype, I wanted to get feedback on this template. I knew this was asking a lot of my peers. It would certainly take more time than just answering survey questions. I asked 13 primary care nurses to play around with the template in the electronic chart of a test patient. I was interested in finding out if the overall design and layout were easy to use, how effective it was for documenting. I also wanted to know what obstacles might prevent nurses from using it on real patients in the clinic. I received 6 surveys back. The format and ease of use was unanimously positive. Nurses liked the idea of having built-in links for education and consult ordering. However, the links didn't function properly. 2 of the 6 respondents commented on how pleased they were with the descriptions provided in the wound assessment portion. And 2 people commented on the Braden scale itself. It was not clear that this portion was required before exiting the template. This caused a little confusion and a delay in being able to complete and exit the process. Several themes arose as perceived obstacles. There is concern about the time it would take to complete skin assessments on all patients who are at risk. The White River Junction VA has over 10,000 patients. On average, there's about 100 patients scheduled a day for routine visits. The number of walk-ins and patients scheduled in the nurse clinics can fluctuate a great deal on a daily basis. There is real concern that demand could easily exceed nurse capacity. An RN that transferred to our clinic recently made the comment to me, of all the positions that she has held at the VA, she's never been as busy as she is in primary care. Patient and clinic flow is another theme. We don't have enough rooms for providers to use more than one exam room. So after a patient has their vital signs taken by the health tech, he or she returns to the waiting room until the provider is finished with the previous patient. There's also the attitude I mentioned earlier. We don't need to be doing this. So, what's next? We need to do some tweaking of the template. We need to determine why the links aren't working properly and fix them. And we need to label the Braden field as required. We need to establish a training session as a refresher on wound assessment and documentation. We'll need to conduct a pilot on one team to come up with ways of weaving this into clinic flow. And then we're going to spread the process to other outpatient settings like urology, outpatient surgery, and our CBOCs. CBOCs are community-based outreach clinics. The White River Junction VA has 7 of these scattered through Vermont and New Hampshire. They provide primary care as well. Finally, we'll develop an annual competency module. Thank you.